I made my first trip to Haiti in 1999, working for another organization called Friends of Haiti Organization. We built a school, and I kind of fell in love with the country, to be honest with you. The people were amazing. Abject poverty everywhere, high unemployment, high illiteracy rate, but beautiful, beautiful people in desperate need. And I just sort of fell in love with the country, and I really felt God was calling me back to Haiti. And so 3 months later, a pastor friend of mine called, said he took a tour of a parachurch organization in northern Haiti. They had a clinic. He walked into the clinic and knew they needed help. My name came to his mind. So he called me. I had a duh moment because I was planning to return and build another school with this other group. And I ended up visiting that clinic, and Randolph World Ministries was born from that. So the following, 3 months after my pastor friend called me, I called the organization he'd previously visited, asked them if I could come to their clinic and see if I could help in any way. Of course, they accepted that offer. And 3 months later, the summer of 2000, I was in Haiti doing medical mission work. I was alone because it was just an experiment on my part. But that's where Randolph World Ministries was born. And over the years, I've learned a lot about medical missions, and we've shaped Randolph World Ministries according to the things I've learned, the things I've read, and what I've observed over time. So we've been operating for 17 years, and we've grown from myself visiting one clinic and only in the laboratory, since laboratory medicine is my background, to making 2 mission trips a year. We have 27 clinics we partner with scattered across the entire country of Haiti. And I send materials to these clinics on a rotational basis, about monthly. I have email communication with all of them daily, not every clinic daily, but at least 1 or 2 clinics on a daily basis, acting as a consultant, advisor, trainer. And if there are medical questions I can't answer, I have a team of healthcare professionals I can call upon, and we can corroborate and send back medical information that's accurate for that patient. The word unique would really imply we're the only one, and I can't say that we are unique, but I think we're close to unique. In my experiences of watching medical mission ministries, and I want to iterate at the beginning, there's no such thing as a bad medical mission ministry. All medical mission ministries do some good. Even ones that do the least good are at the very minimum infusing their money into the economy of Haiti, because they're eating food and drinking water and paying for their accommodations while they're there. If that were all that happened, that would be good. Anything above that is better. However, our model is close to unique in that I believe it's sustainable. The reason it's sustainable is that we don't go to a country and deliver health care in close proximity to an existing clinic in Haiti. We partner with those existing clinics, and we pair up our healthcare professionals on our team with the corresponding Haitian healthcare professional, and we observe them first thing. The assessment is the first thing we do to a new clinic that we've taken on as a partner, and those partnerships are for life. Hopefully longer than my life, if there are folks behind me, especially my children, who might take over this ministry when I can no longer do it. So that partnership is lifelong. And what we do in that assessment is we determine all the things that they're doing that are being done very well at a high level, and we praise them on those and encourage them to continue those behaviors, activities, and procedures. Those things that need improvement, we divide them into 2 groups. Those that are egregious errors that need fixed immediately because they have significant negative health impacts, and we fix those on the spot. We don't see those all that often, but we have seen them. Most of the errors are not egregious, but they do lower the standards and increase the error rate in diagnoses and treatment. So we prioritize those based on the importance of making the change, and then the ability to actually make the change. It's impossible to take Western medicine into Haiti. That's impossible. That's what most team members want to try to do. do what they do at home in Haiti. You can't do it. Most clinics don't even have electricity. And those that do power their own labs or their own clinics. They power their clinics with little generators that are hardly bigger than my lawnmower. They're so underpowered the lights flicker. Can you imagine what sensitive medical instruments would do under those circumstances? Not to mention the fact some days they have gasoline to turn their generators on, some days they don't. And some days they have the money to buy the gas for the generator, they go to the gas station, they have no gas at the gas station. And sometimes there is public power, but probably most of our clinics don't have access to that public power. But those that do have access to public power, it's on about 50% of the time. And the majority of the time it's on is overnight. So those are the barriers we have to overcome, not to mention clean water, under-trained staff. There's no climate control, so instruments overheat. With no climate control, it's open air clinics, so dust is everywhere. Not that many roads are paved, so there's just dirt and dust. Many, many barriers we have to overcome. We cannot transplant Western medicine into Haiti, so we have to find creative ways to find this list of procedures they're doing that need to be improved and find ways to improve them. And that's part of our prioritizing system. Those that we have the capability to improve are top of the list. And so then we spend the next few trips improving their daily activities. So when we leave, they're doing things differently, better, correctly in our absence. That's sustainable. Our primary activity I described earlier as assessing, training, partnering lifelong with our clinics. We accept new clinics. We're up to 27 at this juncture, scattered all across the country of Haiti. That's our number one priority. I would say number two probably is our mobile clinics. Now, most medical mission groups, that's all they do is mobiles. And unfortunately, many, in my opinion, don't really do their homework adequately before they go overseas, and they'll do a mobile next door to an existing clinic, which basically puts those clinics out of business. And so when they leave, that clinic is no longer active, and those local patients have no place to go. We only offer mobile clinics in very remote areas. Some of the remote clinics we've offered, we had to take our clinic, which we pack up in crates, and put them on donkeys and walk alongside a donkey 2 or 3 hours up and over a couple mountain ranges to get to these remote areas. Some of the areas we've gone to, when we ask our patients, I'd say some of them, around 50%, have never seen a physician in their life, and they're middle-aged to elderly. And of course, we have lots of children and babies too that need medical care early, especially if they have inherited conditions. So that's where we go. That probably number three after that would be the programs we offer in our mobile clinics go beyond primary care. We offer eye clinics. We've partnered with a ministry in Kentucky called Kendall Optometry Ministry that has created a system, a computer program system that's tethered to an autorefractor. The autorefractor can test the eyes, determine the prescription, compare it to the computer software which translates that prescription, and then it screens our used glasses database. We have 1,440 pair, that's our working inventory in our inventory at any point in time. So it will take the autorefractor will give the prescription to the computer, which will translate it into a common language. Then it will scan our 1,440 pair of glasses, and using optometry rules, prioritize those glasses into the top 20 matches for that patient's prescription in order of priority, and tell us what bin they're in. So for example, the best match might be glasses number 612. We'll go to our inventory, pick out 612, put them on the patient. 9 times out of 10 they walk out happy. Sometimes that doesn't work out, and usually when it doesn't, it's the frames and not the prescription. And then so we'll go to the number 2, which might be pair 1,213, and we'll pull that one out. And so we can match patients' prescriptions very accurately. Then we'll keep another 2,000 pair in our secondary inventory. At the end of the day, we'll replace the 100 to 200 pairs that we have distributed that day, so the next day we have a full inventory. The third thing we do is a laboratory screening program where we'll go into clinics and take their samples that day, de-identify those samples, and run laboratory tests using techniques that are workable in Haiti, meaning they have to be extremely cheap, very easy, very fast, and accurate and precise is a given. I find these assays around the world that are not FDA approved. I validate them in my research lab. Many of the techniques we've created in our own research lab, and then we bring those in and test patients. We find diseases that are not on the radar of Haitian clinicians, and we can then find laboratory tests to test for them, and then that can be part of our next round of training. We introduce these tests into their repertoire, train the clinicians on what symptom sets to look for, how to diagnose, train the lab staff on the use of these testing devices, and then ensure that the pharmacy has the necessary medications. So for many things, we can, if the test is cheap enough and good enough, we can diagnose diseases that are treatable within our budget. And all those things have to be taken into account. We've done other things as well, like we've started new businesses to help stimulate the economy. We've done a lot of disaster relief after the floods of 2008, the earthquake of 2010, and we're doing it right now after Hurricane Matthew hit the Southwest Peninsula. Also, we just got word that well, not just got word, but 2 weeks ago, rain started in the north, the opposite end of the country as Hurricane Matthew. And it's been raining for 2 weeks, and it stopped 2 days ago, and there's massive flooding in Cape Haitian. So we have a Haitian team down in the Southwest Peninsula working with people providing food and water and cleanup for people in the Southwest Peninsula in the Jacmel area and the Lacaille area. And then we now are dispatching another Haitian team in the north for the flooding in Cape Haitian. We believe that's a much more sustainable model than us going over. Because if I go over to Haiti to help out, number one, I don't speak the language that well. Number two, I don't know the culture. I don't know the geography as well. And most importantly, it's going to cost me a minimum of $1,000, maybe as much as $2,000 just to be there for a week. That $1,000 to $2,000 will feed about 600 people. And so what our model to be sustainable again is to create a network of trustworthy and noble Haitian people who are unemployed to begin with, who can deliver our finances in the form of food, water, and manual labor to help these people much more economically, and our money goes much further. I personally don't necessarily see advocacy as something we suddenly do. I see advocacy as an integral part of who we are. And many people that come to St. Louis University are born with that and raised in an environment with that kind of thought pattern, that we are not on this earth for ourselves, we're on this earth for one another. And every person on this earth has a role in sustaining one another. Now, those of us who live in developed countries, I believe, have an added responsibility. Everyone has a responsibility to help one another. And I believe that's what advocacy is. Raising the bar for those of us in developed countries, we have a double measure of that responsibility because we have so many more resources to offer. Now, our advocacy for patients in Haiti is because our ministry is a medical mission ministry. And so we advocate by recognizing, number one, there is a need. Now, we've selected Haiti, but there are many places all around this globe and in our backyard where needs are visible. They may or may not be medical needs, but we all have different skill sets and different desires and different callings. I am a hematologist, and my undergraduate's in Medical Laboratory Science, so I see myself using those skills in medical ministry. So we advocate for our patients because when we first visited Haiti, we saw the dramatic need, that the lifespan of a Haitian is going up, and I like to think that has something to do with our efforts and other people like us. When I first started in Haiti 17 years ago, it was 42 years of age. according to the World Health Organization and the CDC. Now it's 50 years of age. I'd like to think we've made an impact, as minor as it might be, in those change in statistics. With the media today, I think it's nearly impossible not to have an idea of the economies, the healthcare systems, the standard of living in countries around the world. Many countries are similar to us in those areas. Some are not as advanced as us, but still very sustainable, and some are in abject poverty. In today's world, I think we're aware of that. However, living it and seeing it firsthand is a different experience. Having a human being who hasn't eaten in a week and who's skinny, maybe even having some bloating occurring in their abdomen from edema, from lack of protein nutrition, seeing that person is different than hearing about them on the news. Because on the news, it's a group of people, it's a country, it's a civilization. But that is a human being, and that changes everything. That takes a person's desire and fuels it. It puts a voice, hands, feet, to what we innately have inside of us to begin with. And it motivates us to be part of the solution. Because I really believe that there's really just two places to be. I don't think there's a middle ground. I think we're either part of the solution or part of the problem. And we can be a part of the solution to different levels, but it doesn't matter what level we are as part of the solution. As long as we're part of the solution, that's, I think where we are headed. So seeing abject poverty, I think, is probably the most important feature in putting people into motion and getting people moving in the direction of a global citizen. Now, we also think about global citizenship in other ways other than advocating for marginalized people abroad and in our backyards. We think about how we spend our money, how we use our time, what we do with our trash, how much fossil fuels we use. There are lots of ways we could become better global citizens. One thing I always tell my teams when we're in Haiti, we fund ourselves. Everybody in Haiti is a volunteer, they self-fund. And so when we go to Haiti, not only are we doing all the things I previously mentioned to help improve the healthcare system in Haiti, but we are also providing jobs just by our presence. Because when we bring our money in, we buy our own food, we buy our own water. But we're hiring people to go to the grocery store for us, we're hiring people to cook for us, we're hiring people to clean our rooms so that we can be in the clinics doing what we can do, partly for that reason and partly because they need a job. And we're hiring the people to do our transportation. Randolph World Ministries chooses not to buy a car and leave it in Haiti for 50 weeks out of the year and then use it 2 to 4 weeks out of the year. We hire people who do that for a living and don't have enough customers, so that when we get there, we can hire them and put them to work. That's global citizenship too. And so how we spend our money is important, I think, in redistributing. That's part of global citizenship too. Yes, so we have a website. It's www.randolphworldministries.org. So if you can remember my last name, Randolph World Ministries is plural and all strung together with no spaces or no capital letters, .org for organization. I must admit, being a full-time faculty member and a father and running Randolph World Ministries pretty much alone, I don't have enough time to really keep my website in tip-top condition, but it's still very informative. And it'll give you plenty of information to make initial decisions if you value our work and if it's something that you're called to do. There are many callings out there, and your calling may not be consistent with what we do in Randolph World Ministries, but it may. And if it is, feel free to peruse our website and shoot me an email. There's a link on the website to my email address, and give me your levels of interest. On the website, there's a long list of ways that people can partner. Going on a mission trip is not the only way to partner, and quite honestly, it's not our biggest need. Many other needs we have are much bigger than getting ministry partners to go on teams with us to Haiti. That seems to be one of the more popular ways to help, but it's not the need that is the greatest for Randolph World Ministries. So email me if you're interested, discuss what kinds of areas you're interested in partnering with us, and I will set you up so that you can partner with us in the ways that best fit your skill set, your desires, your calling.